Good morning, everyone. Welcome to our session today. It is 9:08, and we want to keep English time. Today it's Friday, so we also want to ensure that we can finish early enough so that we also continue with other things. I can see the director has joined us, so she will start us off with some comments to invite us to the meeting, also give her general comments before we begin. Today we have two documents. The first one is the National Guidelines on Alcohol and Drug Use Prevention. And this is the bigger document. I'm saying the bigger document because shortly, once we are done with this one, then we'll be looking at the national guidelines for schools. So these ones were originally called standards, but we changed the title guidelines, and later on we'll tell you why. And so this document is available on our website. You can download if you haven't done so. It's very important that if you work in NACADA, you also know which are our working documents so that you are also help to educate people out there on the right things. So director, if you're ready, you can start us off.
Good morning, everyone. My
Good
internet is
morning.
about to go. I'm glad you can hear me. So thank you for joining us today. We all know how important these guidelines are, and to ensure that during dissemination and sensitizations, we are actually doing what the guidelines are supposed to do. I am very happy that we are doing this sensitization to ourselves today. So the members who have not joined, kindly remind them. And for us who are have already joined, let's pay attention. Let's seek clarification during the presentation so that even as we step out to reach to fellow Kenyans, we do that and do it very conclusively. Thank you, and I'm hoping that we'll be together during the two presentations. Over to you, Susan.
Thank you. So we have the chat. And so if you have questions, you can use the chat. We'll also have an opportunity for people to also just raise up their hands and speak. So the first document I'm going to present is the working document, the Bible. If you're doing prevention, then this is your Bible. And this is a document that has been developed in collaboration with a number of stakeholders. That is NACADA, forming the secretariat. Although sometimes when we talk of secretariat, it almost sounds like you are doing secretarial work. Yeah. So it's been developed by NACADA in collaboration with other stakeholders, drawn from different settings, from Ministry of Education to take care of the school settings, from public sector institutions. We had the Public Service Commission represented. We had some of the public sector, the Public Service Commission itself, and then some drawn from the some of the public sector institutions that have also been actively engaged in this. We also had representatives from civil society organizations because you know that we have the community setting. We also had the religious institutions also represented by NCCK, and you know that NCCK is an umbrella of quite a number of institutions. So all these people worked through this document. Despite the challenges that we had with COVID, we were still able to work on this. A lot of the work was done online. It's something that began way back in 2019. So in the other financial year, we had started it, but with COVID, again, you know, things kind of stalled. So we were able to finish it in the last financial year. And this is the document that was launched on 26th of June. So just bear in mind that you all require a copy, get it from the website. Unfortunately, we did not produce any hard copies. Maybe with time, if we get um, a sponsor or somebody who can support us in producing more copies, then we will do. But as a regional office, if you would want a copy for yourselves, then you can actually produce one and keep in your office for reference. So the guidelines has 6 sections: the introduction, the rationale, it has the goals, objective, and scope. We have the standards and the guiding principles. Then we have the alcohol and drug use prevention interventions and policies. And we also recognize that there are quite a number of gaps even as we do this. And so we have areas that require further research. So it means that either as an institution or those who are interested in doing research, even those ones we do in partial fulfillment of something, these we have actually identified some of the gaps that can be researched on. So straight away on introduction, as an institution, you know that we respond to SDG number 3, and that is good health and well-being. And specifically, we respond to 3.5, which is to strengthen the prevention and treatment of substance abuse, including narcotic drug abuse and harmful use of alcohol. In addition to that, you know that as the authority responsible for all this, we have done surveys. And now the surveys, we are translating our surveys into meaningful interventions. So you know that in 2017, we had the national survey done. We are in 2021, 2022. You know that these are 5-year surveys, so we expect the next national survey to be done in 2022. We have the secondary school survey, and if you're not familiar with them, kindly get to the website. They are available there. And then we also have the primary school survey. So the 2016 and 2018 survey helped us to come up with the school guidelines that we shall look at once we are done with this one. So we know that all these surveys actually point to the prevalence of alcohol and drug abuse in Kenya. And we know that tremendous efforts have been made to mitigate the growing problem. But we know that there is need for effective strategies so that we can ensure that children and young youth can stay healthy and safe as they transit into adulthood. That is because initiation of drug use begins much earlier, as shown from the primary school survey. We also have the international standards. So international standards on drug use prevention is supposed to help governments to develop programs, policies, and systems that are truly an effective investment in the future of children, youth, families, and even communities. So what we have done is to domesticate these international standards so that we can have standards or guidelines that help to address our local situation, bearing in mind what governments are supposed to do. So, what is it that we have been doing? And we are familiar with this. As an institution, you know that we do awareness raising. We like to hit the ground running. We have developed quite a number of materials to read, T-shirts, say no to drugs, drugs is the highway to hell. You know, we have done all this. So sometimes you don't know whether should we talk about specific substances, and we've had situations where people want to talk about giving more detailed information on alcohol, on tobacco, or other types of drugs. So you ask yourself, if they are abusing alcohol, should I give them more information on alcohol? Because probably we think that once we do this, then they will have more knowledge, and therefore that will help them to reduce. We have had all these one-time events, a few hours. So what has been the frequency in terms of the messaging? And then, do we target adolescents? Is it the young adults? And this broad term, we say youth, youth are the most affected, and so on. So what we have actually resulted with is this picture here. It's not clear. And many times we are convinced that when we scare them, then probably this will help to reduce substance use. So there's been a situation where people are unsure, they are puzzled, you're confused, sometimes even baffled, or sometimes you think that what you're doing is the right thing. And as an institution, the rest of the country relies on us. In fact, if you ever engage with people from the community, they are convinced that if it is NACADA, if NACADA has said this, so it means that we have a lot of power when it comes to influencing the direction that things should go. So now we want to move from that to get into a situation where we can address or provide direction to the rest of the country in terms of how to address or do prevention. So the goal of these guidelines is to provide minimum requirements for conducting effective alcohol and drug use prevention programs in schools, in families, in workplaces, in communities, and also in the media in Kenya. So that tells you that we are already defining settings. We are moving from a one size fits all to specific settings. So, one, we want to advise on best practices in prevention interventions. Number two, we want to ensure professionalism in planning and also implementation. We also want to provide minimum requirements for service providers. Even when you do prevention, you can cause harm. And so, as service providers in prevention, this document also provides the minimum requirements. And then we also want to foster development of national prevention system. So that is something that will also be coming in the new in the current financial year. So this document is to be used by all stakeholders who are involved in the development and also implementation of alcohol and drug use prevention programs in Kenya. So it starts from you and spreads out to all the others. So now I want to take you through the prevention standards and principles. And if you have that document, then you can see that this section, that is 3.0, will provide us with overarching framework for implementation of prevention interventions. And there are 8 governing standards. So I'll just briefly take you through so that I can whet your appetite for reading the actual document. So standard number 1 has to do with the settings. Prevention works in settings so that the target populations are found in specific settings: the family, the school, the workplace, the community, and also the media. So you're going to find that in these settings, prevention programs can also be described as per the audience for which they are designed. So it's not a one size fits all. So when we talk of universal, universal is you talk of the larger population. And most of the people you find, or the audience you find in Universal, are not using drugs, have not started. So that is why it's called Universal. So it means that we also have programs that need to target the universal population. Then we have the selective. Selective population is the one that are at risk for substance use. For example, it could be children who are born in families where the parents are already substance users or have a problem or already experiencing a substance problem. So they are probably living with substance use disorders. That's a selective population. Even the youth are a selective population because of the developmental stage. They are they are more prone. They are not yet using, but they are at a higher risk. So you'll find that in all these settings, in the family, in the school, in the work setting, and also in the community. Then we have the indicated. The indicated group are those who have started using but have not become dependent. So you can see we need to have programs that targets the general population, most of them being non-users. We have selective for those who are at risk of using but haven't started because of one by the nature of where they are. And then we have the indicated, the audience that have started using but are not dependent. Now, once they get into use and therefore become dependent, they cross over to the treatment side. So bear in mind that prevention targets those three populations. So the setting number one is the family. This is where it all begins. Children are born into families. Families are the basic socialization agent for children. So that is why the family becomes a very key setting. If things go wrong in the family, it's going to go wrong in the community or in the school. So families have a very strong influence, and even our own survey shows that it is the family or the home environment that is most at risk. This is where initiation of substance use actually begins, not even in the school setting. So from the family, then we get to the school, because you know that once a child gets to the age that they are ready to get to school, then they are going to transit into a school setting. So the school setting is another setting that we work on. And today we are going to share on what is it that we need to do with the school setting. Then we have the workplace, that once people transit from school, the next environment that they will find themselves is the workplace. So we already have workplace programs. You are aware of performance contracting and the fact that we have the workplace program already in place, particularly with the public sector institutions. But we also need to look at the informal workplaces. So that is the next setting. And then we have the community. And many of you are aware of this. And in the community settings, then we have rules, we have laws, we have regulations. So this is where, when we talk of ADCA as we know it, the Alcoholic Drinks Control Act, it needs to be implemented. If it's going to be implemented, it has to be in the community setting. If we have the tobacco laws, that also prohibits smoking in public places and so on. Regulations with regard to even licensing, where should we have um, drinking places, for example. So community becomes the other setting. So for family, then when we look at the guiding principles, we are saying that if you're going to have a program here, it should aim at changing behavior. What behavior needs to be changed? It needs to enhance family bonding and relationships. Programs here need to consider the characteristics of the families to be served, because we know that there are unique differences. For example, because most of the programs that are done targeting families, particularly in our setting, we tend to focus on the faith-based organizations. So it means that if it is, let's say, a Muslim community, that already is a characteristic of families. How do they even work around their families? If it is in a Christian setting, and if it is a broad setting, what are the things that we expect to see? You also need to um, bear in mind the cultural and socio-economic needs of the families that you are targeting, and then matching the level of risk in the target population. Remember, we said universal, selective, or indicated. So the program needs to match the level of risk. So that means we do not have a one size fits all. Then still in the family, it needs to match the specific needs of the families. It also needs to be age and developmentally appropriate. So that means you're talking of parents with children of different ages. You cannot have one program that deals with parents with children who have not started going to school, combine them with the ones who have adolescents or have college going students, children, for example. So you can't have a one size fits program. And some of the programs that we hope to do will be, for example, um, Strong Families program, because it targets parents with children of specific ages. Then we are saying that these programs also need to have adequate intensity and sufficient dosage. You cannot have one session and that is enough. So when we talk of intensity and dosage, it means that, remember, you are aiming to change behavior. You cannot change behavior in one setting, in one sitting. So it means that we need to have a number of sessions. For example, you've seen what we've been doing with the positive parenting, um, 5 sessions where we discuss different topics. So that is why we are talking about intensity and also dosage. When you have family programs, it also needs to be interactive. It's not where you are the one who knows and therefore um, wants to speak to parents. So it needs to be interactive in nature. And such programs, you cannot have more than 12 families. Because remember, when we talk of families, we are talking of children and their parents. So if, let's say, it is a program for 10 parents with children 10 to 14 years, most commonly they are likely to have 2 or 3 children. Then you add the parents, assuming even just one parent is coming to that program. And then you have the 3 children. That means you already have 4 people from that family. Times 10 families, you can see the number is already big. So the bigger it is, the less interactive. And that is why it needs to be made interactive so that parents also feel valued. It also needs to be delivered by people who are adequately trained. And that is why training becomes important. And then we must include a strong component of monitoring and evaluation. What is it that we intended to change so that we are able to see the progress in terms of that change? So that is the family. And I want to move to school. Remember, if you have any questions, comments, use the chat, or you can write it down and then you will call. So in the school setting, again, age specific. And here, what I would say, we've even worked with the um, KICD, Kenya Institute of Curriculum Development, so that we have content which is age specific, because the risk factors for different ages are not the same. They are designed, these programs should also intervene as early as preschool. We don't wait until they get to adolescence, that is when we want to address the issues. It's a little too late. So there are certain things that we see, like aggressive behavior, poor social skills, academic difficulties, so it needs to start early. And then we also have those that are targeting elementary school, and we say that here academic and social emotional learning, so that you address the risk factors for drug abuse. And the CBC parents, you know that we're already moving into those terms like elementary, middle, junior, and senior secondary school. So uh, don't wonder why we are not talking about Form 1 or Form 2 and so on. So those are the new terms in terms of what is new in the CBC. So again, you can see academic challenges, school dropout, academic support, early aggression. Those are some of the things that contribute to children actually beginning to use drugs. And so prevention programs for middle, junior, senior school students should also increase their academic and social competence, self-efficacy and effectiveness, and drug use refusal skills, among others. So that is where the life skills program. So if you hear about the life skills program, it's already addressing these examples that we are talking about. So those who are doing those programs, you are very familiar with it. Then we come to the next primary setting and community, and we know that here we are aiming at the general population in the community. And then it means that we need to, in the community, there are so many things that happen. Even the schools are in the community, workplaces are in the community. And so interventions should not single out risk populations, because if you want to target the drug users, for example, or you say these are the populations that are using, so now we want to target them because the drug users, the injecting drug users, you bring out labeling. Yeah. So remember that the whole idea of prevention is to promote bonding to school and even the community. So you'll find that targets mainly the transition points. What is it that is happening in, in the community? So whether it is within the school or it is the workplace, the religious institutions, all those form part of the community. Then again, these programs should combine two or more effective programs. It doesn't make sense if you are only targeting the school, but you don't target the families. Or you target the schools, but the workplaces, for example, Juakali, are left out. So it is more effective if you have more than one single program. And then community programs also need to reach populations in multiple settings. That's what I'm saying. The school, the clubs, the faith-based organizations, the community-based organizations, the media, so that a combination of all this will help to reach out to many more. We have the workplace, and the workplace, the programs we are already implementing, including, and I'm happy that most of the people who are signed in today are also signed in the online workplace setting, that workplace program that we began yesterday. So you are going to find that it is in line with these principles. The content should be based on proven theory and research. And so research forms a very key component. Even in our own situation, we have done survey to even look at the situation of alcohol and substance use in Nakada. So any programs are going to be based on the research. And then it should be comprehensive in the sense that it addresses the multiple risk and protective factors, and then which can also be generalized across the settings. And I would want to mention that even our research department have also done um, survey, a national survey for workplaces. So once it is released, it's going to fit in very well with what we are doing here. And we are saying we need to provide material that is relevant during important transition periods in an employee's life and career. And then it also needs to be sensitive to the culture of the workplace and community. So the programs that we do in the workplaces targets that. They should also have sufficient dosage and follow-up. So we begin with the training, then we have sensitization, then we also do follow up, and that is why they report to us. So sufficient dosage is still important here. When we train, we also make use of interactive teaching techniques. Even yesterday, those who are there, even at virtual level, we still aim to have interactive techniques. And it is important to train prevention program providers. So the reason why we are training in workplace so that you can become prevention providers, program providers for other workplaces. And the component of monitoring and evaluation is always there. It cannot be left out. Otherwise, you will not know if what you are doing makes sense. So that is standard number one. And you can see standard number one is bringing out the settings. So as you go out in the field, the question you should be asking yourself before you hit the ground running, who is my target? If you go to a school, who is my target? You can't have from 1 to 4, for example, because already their issues are different. So that is why we need to take that into consideration. So the second one is talking about age appropriateness. The programs should be age appropriate. So that programs should aim at addressing the specific target group needs and also age specific messages. That is why if you go to our website, you're going to find even our booklets. We have moved from what we were doing previously into having age specific or messages so that um, 6 to 8 year olds have a different message from 13 to 15-year-olds, for example. And that's the same thing that has been done even in the content for CBC. It begins much earlier than 6 to 8 years. Then we need to provide clear structure. The programs should provide a clear structure so that it is clear how long is this program, what are the length of the sessions, what is the frequency of implementation. For example, those who are doing the life skills program, LST, you know that it's very clear. Lessons are taught in order. The lessons last 45 minutes. It is done for, there are how many? Once per week. That is the frequency of implementation. And we know that we also factor in the aspect of following up to see if the teachers are doing what is needed to be done. It also needs to bring out the appropriate language and activities that need to be relevant to the specific target group so that again, if you are going to implement programs, then the language has to be at the level of the target group. And I know that means that some of our documents we may even need to translate into Swahili, for example. So we need to ensure physical and emotional safety of the participants. Even in prevention, you can cause harm. So we need to be aware that sometimes you can be reaching a universal population, but back home, they also have somebody who is having a problem. So we need to be um, cognizant of the emotional safety of our participants. And then we also need to be aware of where referrals can be made. So provide referral for other individuals like services for children and other youth-friendly centers. So in your regions, where could we otherwise refer um, children or young people or even people in need of treatment? Because you may be addressing a universal population, but once you finish, they come and tell you about a specific issue that they have. And so it means that we need to be aware of where can we refer? So that even when you say call 1192, does 1192 also know where referrals can be made? So that is very key for age appropriateness. Now, the other that we are talking about is that you are a prevention practitioner, or we are working towards making you a prevention practitioner through training and other skills development. So we are saying that we also need to be guided by professional ethics in development and also implementation of programs. So here we are talking of competence. Are you probably properly trained and skilled? Or just because you work at NACADA, you will go to the field and say, sometimes even contradicting what the institution is talking about. Yeah, so the aspect of training, confidentiality, we also still need to observe confidentiality when we are handling participants and even institutions' data and information. Like if we deal with the public sector institutions, part of what we want to see them do is to reach out, establish um, programs, EAPs, employee assistance programs, and sometimes the data they may be giving has to do with the people who have gone for treatment. How are you handling that kind of information? And then informed consent, even programs, you still need to inform your participants about the objectives, the processes, the duration, and so on. And those who are doing LST, you know that we went through this. Even having 1 day forums for the head teachers so that they get to understand what is it that we want to do. Then there is the aspect of beneficence. It needs to be tailored to address the risks that are specific to that population. So in as much as all our counties have issues, we know that the issues sometimes are specific. And that is why we cannot have a one size fits all. There's a way in which you need to tweak. And malfeasance, do no harm. Even in prevention, we can do harm. So when you go and start giving details, alcohol, this is what alcohol does, and then you go to the next substance and the next substance and the next substance. Then, and you're talking to children who are in high school or even primary school, then you are creating a situation where they begin to say, wow, I didn't know that there is another one. Yeah. So you end up creating curiosity, and then they get into using that when that should have not happened in the first place. So remember, here you can also do harm. And then respect and conditional acceptance of participants, irrespective of who they are. And also honesty, meaning that we need to provide truthful information. You cannot know everything, but it is bad enough if you give incorrect information. Even for myself, if I am not certain, I will say, let me go and find out, I will get back to you. So we need to provide truthful information, including when we do research, because we are saying evidence-based comes with research. Standard number 4 has to do with inclusivity and non-discrimination. So as an authority, we know that we are responsible for all programming, prevention, and even treatment. And so we need to promote active participation of the community. So in those settings, we still need to ensure that we do not have people who are left out. I know sometimes when we have programs, then we must make a conscious effort to include even persons with disability, so that even as you mobilize, sometimes it's important to specify. Yeah, it's important to specify uh, that please, as you mobilize, please also bring in persons with disability, because they tend to be left out. So inclusivity and non-discrimination is very key. So as people who are implementing programs, for example, we are going to be reaching out to out of school youth. It means that we need to make a conscious effort to ensure inclusivity. The other standard is on risk and protective factors. And you know that in matters of alcohol and drug use prevention, those are the two key things that we look at: risk factors and protective factors. What are the risk factors in that population? So our programs need to reduce the risk factors. Yeah, need to
Reduce the risk factors and enhance the protective factors. So if you look at any community, what are their risk factors? And then what are the protective factors? We need to also, programs need to address all forms of drug abuse. So whether we are talking of underage drinking or underage use of drugs, so we are not just talking about alcohol, but it's alcohol, tobacco, and any other drugs.
you're talking of illicit drugs, then we broadly talk about it. Inappropriate use of other substances like inhalants, prescription medications, because that has come out from our research. So it means that we address all forms of drug abuse. We also need to address the type of problem in the local community. What is the problem in the community? And that, is informed by research. So from our surveys, um, what is it that our research is saying about that particular community, so that we don't just say, the problem is at the coast, yeah, and the problem at the coast is heroin, when even our own research says that the bigger problem, even at the coast, is still alcohol. Yeah, it's only that there could be a level of community readiness. So, what are the things that we can change? Yeah, that is what modifiable risk factors. Can you identify what can be changed within that community? What are the protective factors within that community? Because if they have a strong religious following, for example, that could be a protective factor. So, how do you use that protective factor to address the issues in that particular local community? So, again, you need to tailor. Yeah, programs need to be tailored to address the risks specific to a given population or audience. So in terms of gender, in terms of age, in terms of ethnicity, yeah, so that we can improve program effectiveness. So what we are saying here is that there is no one size fits all. So that once you are given a presentation on positive parenting, then even when you are not parents, you just go there. Yeah, it means that you are not addressing what is specific to that population. So we need to be conscious that if we are going to have or improve program effectiveness, then we must ask ourselves, who is my population? What are their risk factors? So that even if you are invited to go and speak to a group of youth, for example, then you must ask yourself, what are the challenges there? You don't say youth is the same, one size fits all. Because you have this presentation, this is what you're going to talk about. So there is the aspect of tailoring. Now, the other standard had to do with delivery. And we've said the program should match the needs, the norms, the differing cultural requirements, but you still retain the core elements of what the program is. For example, we are going to in with the time we are going to implement the Strong Families program. So there are core elements to that program, but they are community needs. Yeah, which is the best time to reach them out? Do they want it in a given language? What are some of the cultural things that they do with when they have programs? So that is what tailoring or meeting the matching the community needs is about. Then programs also need to be long-term with repeated interventions rather than single event. I know we've been doing a lot of single events and it is so easy because you just do this, pop, you are done, report, tick, done. You check the box. Repeated interventions. So, and that is why you ask the question, what are the risk factors? So that then, and once you identify the risk factors, you cannot do it in one single session. School-based programs should also include teacher training on good classroom management practices, and that's already factored in as part of delivery. And then employ interactive techniques so that if, for example, if you are meeting young people, I know we go to schools and sometimes we want to talk to 1,000 students and so on. You become a lecturer, and you know that lectures don't work with young people. So how about thinking about peer group? Even if it is one school and you want to meet them in different classrooms, you can have from 1 and 2 together, or from 3 and 4 together, but you can't have from 1 to 4 together because their issues are different. What are the challenges? And if you have peer group discussions rather than giving a lecture,
it goes a long way in actually addressing their issues. When it is parents, there is no school for parenting, although right now we need to improve on our parenting skills and therefore training becomes important. So what you need to involve parents. You hear from them, and again, I would want to commend those who are doing the positive parenting, those who went to the media stations, able to ask, respond to the questions that parents are asking. But when we have programs, then role playing also becomes very key because you want to reinforce their skills. And then these programs also need to be informed by research. Seven, we are talking about including M&E component. So our programs should start with a baseline survey or a needs assessment to identify the needs of the community. Some counties have already done the surveys, and therefore it becomes a good point to start because then you know what you are addressing. Even in the workplaces, we insist on baseline survey because then workplaces are addressing the specific issues that they have in their workplaces. And so programs should have indicators and expected outcomes. You don't just tick a box. What is it that we need to see change? And we are doing that for school programs. We are doing that for workplace. We are going to do that even for family programs, and we need to do that for community. So M&D should be linked to specific program objectives that are designed through program planning process. And the examples that we already have is life skills, and even the one for workplace. It is linked. There are specific program objectives, and so monitoring information should be used in decision making so that it informs what kind of programming, what is it that needs to be improved, what needs to be changed, and so on. And lastly, I'm still in seven, and evaluation. So there's the aspect of evaluation should follow a specific methodology. The good thing about programs and not activities, programs is there is always the aspect of evaluation. And so the research component cannot be ignored. So the issues of participation and also involvement of program stakeholders, and the research department is already doing well in this because when we do the surveys for institutions, then they also become part of um, part of the people who are involved in the evaluation process, respecting and protecting the rights and welfare and confidentiality of all those who are involved in the programs, including the life skills program that we have been doing. There is the aspect of respecting and protecting the rights so that even when we collect data, we give them codes, but not their names are found on the research documents, including the one for schools. So again, multiple methods in collecting data, and those who are involved in LST, I'm saying more and more of LST because we are reviving it now that schools are back on course. We don't just have the questionnaires. That is why we have the fidelity checklists so that it is part of monitoring. And then conversations with even the implementers has also contributed a great deal. And lastly, we are talking about prevention programs should address multifaceted area of an individual, should also be comprehensive so that it addresses a wide range of risk and protective factors of the target problem. We've already talked about various teaching methods so that we are not giving lectures. I know it is so easy to give a lecture, like the way I'm lecturing now. I hope you're still with me. Yeah. So you know that lectures is where you tick a box that it has been done. Yeah. So let's use the chat box so that we also make it a little bit interactive. We've talked about the dosage so that we move away from single event activities, unless it is, international days, for example. But even that, we have pre. pre-event activities so that we raise awareness in a, more than just, nothing happening and then on 26th June we have something. So the aspect of raising awareness, even that needs to be done so that there is dosage more than just one. It also needs to be theory driven because when you have prevention, it is also very logical. There's logic about it. So it's not a hit and run kind of programming. And then positive relationships, because we are ensuring in prevention, we are ensuring that we foster strong bonds, stable and positive relationships between children and adults. So again, appropriately timed. It's very important that they are developmentally appropriate. When we begin at high school, it's already too late. They should also be socially, socioculturally relevant so that they fit within the cultural beliefs and practices of the specific groups. But again, we need to bear in mind that sometimes the cultural beliefs within communities is what is contributing to the substance use itself. Like if we have circumcision, and then for the young people, unless we have sessions where then they get to know that, yes, you've gone through circumcision, but it doesn't mean that now you do what adults do. And part of what adults do is to drink. So they culminate the whole process with drinking. So you see, it may culturally fit, but we know that it also works against the very things that we're talking about in prevention. And then systematic outcome evaluation needs to be done so that we can say that this program has worked or not worked. And then well-trained staff. So even in our own context, we are working towards um, building capacity so that our own officers can be able to do this. So that is it with the principles and standards. And now briefly, I want to take you through the prevention, interventions, and policies. What is it that we have? So this is how prevention looks like. We've already talked of settings, the family setting, the school setting, the community setting, the workplace. And you can see the last one talks about brief interventions. And you can see it is in red. There are different colors here. So where you see green, green is universal. So that means that those are programs that target universal populations. So we have like parenting skills, personal and social skills. Um, what else? The school policies and culture, addressing alcohol and tobacco policies. Those are universal interventions or programs. The ones which are in yellow, I hope that's yellow. The ones that are in yellow is indicated. Remember we said the ones at risk. So you can see we have prenatal, where we have um, pregnant mothers going to either clinics, or you have community health workers coming to their homes. So when we have uh, pregnant women and they're also using substances, then you can see why they are become an indicated population, because the yet to be born child is at risk. Early childhood education, remember this is a period of transition. So that is why it is also in yellow. Policies to keep children in school is also a selective program, because we know that this helps to address school dropout. So the ones which are in red are now the indicated population. And you can see it's talk about addressing individual vulnerabilities. We appreciate that they are already learners who have a problem with substance use or mental health challenges. So that is why it is in red. In the workplace, you can see the workplace prevention has all those three. So in the workplace, we need to have universal. selective and indicated programs. And then brief intervention. This is actually counseling interventions. And that is why you see from this, it is put in the health sector. Yeah. But you can see we are already addressing it at various levels. So now I'm going to briefly take you through what are some of the programs that we have in Kenya now. The programs we have in Kenya, in the family programs, we have the prenatal and postnatal healthcare visits. We have the home visits by community health workers, and those who are in the regions, you know why this now explains why we were targeting the um, the healthcare workers. And you know that follow-ups. Remember we said you do the training, then there are follow-ups. So in this year, we are going to do follow-ups of the people that you trained in terms of the home visits. And then family skills and parenting skills. What we have been doing during this COVID period has been positive parenting. And remember, it's an important setting. So if you look at what we have done so far as NACADA, we have so far reached 9.7 million people with the positive parenting campaign. So you can give yourself a thumbs up. Yeah, have that thumbs up reaction as a participant. If you have been involved in this, put a thumbs up there because you have contributed to this. And we know that we have been aiming at positive language, active listening, empathy, to help maintain a peaceful and happy family environment during these stressful times. So we hope that even though we did not get funding, we hope that we will be able to continue to do this. So thumbs up for those who have been doing that, and even those who have supported on the sides. So what is it that works in families? We need to teach parents about being responsive, provide structure, and also be involved in the child's life. We need to enhance family bonding. We need to um, support parents so that they can be more active in monitoring the activities of their children and also their friends. So the parents should be asking, who are the friends of your child? So do you know who they are? And do you know their parents? So if they say they are going to this house, do you know what is happening there? So that is part of monitoring. So we need to work towards helping parents to even do monitoring. And monitoring is not the same as policing. Then supporting parents so that they can be role models of their children. Remember, we said from the survey, home environment is a risky environment now because parents, children will do what they see their parents do. So they need to become role models. Positively, provide positive and developmentally appropriate discipline. And sometimes we want to discipline the way we were disciplined, and that may not be working. And then basic parenting skills. So those are some of the things that we are going to reach out, or we have already been doing, but we hope that this will continue. Children also need to be helped to build life skills. On the other hand, then parents reinforce those skills. Children and youth also need to develop effective problem solving skills. Youth to learn to communicate effectively. Because even when you say no to drugs, and I cannot effectively say that no, then they are easily influenced. Then the peer resistance skills. We said that we need to have a series of sessions. That is what works. And it is delivered by trained individuals. And you'll find that in many cases, it does not require formal qualification. The people who are being trained need to know this is what they need to do. So as you go out and you are reaching out to families, remember, or even young people, you should be talking about skills. Because when you talk about drugs and they do not have skills of resisting, then you are not helping them. If they are not able to communicate effectively about the challenges that they have, then you will be addressing the wrong thing. Again, what is it that doesn't work? So This document also tells us what doesn't work when you undermine the parents' authority. Parents still need to be in charge. That is why we are building their skills. We also don't want them to move away from their roles and say, because NACADA is here, now NACADA can deal with it. We should not undermine the parents' authority. And again, it doesn't work when you target only children. I know there is a strong tendency to want to talk to the children rather than their parents. Parents have a lot more power over their children. So if you only target children, it doesn't help much. And then providing information to parents about drugs so that they can talk about it with their children. That is not enough. And you will find that in our parenting booklet, which is available on our website. So that how do they even hold conversations? So if you just give them, they will also say, please read this document. This book, Nakada says that you read. And you know that if you want to hide anything, hide it in a book. Even children will read for exam purposes. So because it means that you will be approaching it from the one size fits all. Next, we have the school programs, and some of the programs we have in Kenya, or some of them we may not have, the ECDE programs. You know, ECDE is not just about the classroom. It talks about a lot more. And then we have the LST, which we are implementing in a number of schools. Then we have the classroom improvement programs. We have policies to retain children in school. Even the Ministry of Education is working towards 100% transition. So that is aimed at targeting children who may otherwise drop out. And then we have addressing mental health disorders and psychological vulnerabilities. So we aim at also building capacity of those in the school environment so that they can address this. And then the school policies and culture on substance use, that's also been found to be will work when it comes to school programs. So some of the things that we have done so far, thank you Coast Region for taking this photo, and that shows the life skills program that has been going on. So far we have been in 19 counties, 174 schools, 289 teachers have been trained, and up to 11,984 learners have been reached with LST. Now remember that the teachers who have been trained, they should progressively also still reach the next class 5 and class 5 and class 5. That is when they will be able to reach many more learners. So that has to do with our program in the schools. What is it that has been found to work? Teaching learners the necessary skills to resist social or peer pressure to use drugs, increasing their knowledge on immediate consequences of substance abuse. So you don't go to schools, colleagues, don't go to schools and start talking about how alcohol will give you cancer and tobacco, you will die, and all those things. You know, long-term consequences they cannot deal with. The immediate consequences of what will happen to you right now, you will be, you'll get into trouble with the school because it is against the school rules. What will it do to your brain, your heartbeat, you're not being able to think or make decisions. Yeah, get into trouble over this or that. Those immediate consequences of substance use, that is what works. Enhancing cognitive and behavioral competency so that you can reduce and also prevent health risk behaviors. And also, these are some of the skills. When we talk of life skills, this is what we are talking about: coping with anger and anxiety. Those are the key issues of children. Decision making and drug resistance skills, particularly in relation to substance use. And some of the other issues they could be dealing with, and that's why it's important to find out once the school has called you, what is it that they are dealing with? Ask the learners, and you will be surprised. The issues they are dealing with is relationships, masturbation, growing up, academic, and probably if they're using substances, it is to cope with all this. So the issues may be totally different from what you are attempting to address. And then what works? Perceptions of risk that are associated with substance use, emphasizing immediate consequences. If I use bangi, what are my peers saying? If you want to read for long, bangi will help. So remember the immediate thing. If you want to read for long, then bangi will help. So if they perceive that the risks, yeah, the benefits are more than the risks, then they will uh, begin to use or continue to use. So perception of risk is very key. Dispel the misconceptions regarding normative nature and expectations linked to substance use. For example, um, if the misconceptions, everyone is using, so if everyone is using, then I'm the only one who is left out. Yeah, but the truth is most learners are not using. So dispel, what first of all, what are the misconceptions so that you can address them. And the sessions need to be interactive. Avoid lectures. It doesn't help for young people. What works again is involvement of all stakeholders, the students, the teachers, the staff, and the parents. So once we are done with this, then we'll talk about the next document that then talks about what will work in the learning institutions, eliminating or reducing availability and accessibility of drugs within the school settings, the policies that applies to all in the school, not just the learners, students, teachers, staff, visitors, parents. It refers to all, and also all the psychoactive substances. And then what works? Addressing the violations, the consequences to not following the rules, and also providing for referrals to counseling, treatment, and other healthcare and psychosocial services rather than punishing. So it's not aimed at punishing. In fact, sometimes they may not want the school, so they will just use the drug so that they can be sent away. Yeah. So you see, for during that time, it has worked for them. What is it that doesn't work in school settings? Non-interactive methods such as lecturing. When you give information alone, like posters and pamphlets, when you have those presentations that are supposed to scare, yeah, those ones are actually found not to work. Single event dialogue sessions, unstructured, because you don't even have a plan. You just have your PowerPoint and this is what you want to do. Focusing on self-esteem or emotional education, that has been found not to work. Remember, there are many more things that young people would be dealing with. Those ones that address moral decision making. Yeah. So sometimes morality has to do with even trying to address it from a religious point of view. Ex-drug users as testimonials does not work. And more you see that we have been discouraging this because that is not linked to positive outcomes. Random drug testing in schools that is not linked to any comprehensive program. And colleagues, we need to be aware that drug testing is not an intervention. And that is also addressed in the one for the school guidelines. And I know sometimes you find people who have brought letters because they have been told you must come back with an ACADA letter and so on. It is us who need to dispel those myths and give correct information. The ones who are sent to your office so that whatever intervention you're supposed to give them, so that they can go back to school with a letter. So now, even you will have a better way of handling that. So if it is counseling, then where can you refer them, or is it going to be done within your own setting, and so on. So that doesn't work. Then we come to the workplace programs. And thank you for those who have been participating in this. Wambisa, I hope you can see yourself in the photo there. So what are some of the things?
the ADA prevention and management policy, employee assistance programs, brief intervention, and referral to treatment. So our program is already comprehensive enough. And some of you, I'm sure you can identify in which setting this was, where you also trained public sector. So we have a huge mandate of reaching out to public sector colleagues in the region. So a lot more is going to happen. In the last financial year, we reached 132 public sector institutions, but there are much more than that. So baseline surveys, the workplace policy, training and awareness. So all these are components that we need to do, and it's a huge mandate. We have quite a number of institutions right out there in our regions. So what works? Involving all stakeholders. We also need to guarantee confidentiality. That is why sometimes employees do not present themselves. Even when you know they have a problem, they will deny, deny, and deny because they think that, even accepting will not, it's not about help, but probably punishment. So guaranteeing confidentiality, the policy on substance abuse management in the workplace, that is very key for us. Brief interventions, and remember this is counseling. There is also referral to treatment and reintegration services to employees who need them, and including a clear communication component. So it means that even our policy needs to be disseminated so that even NACADA staff can know what is this policy about, what is it, what's in it for me as an employee. So it needs to be disseminated. It needs to also be embedded in other health and wellness related programs, because part of what we address is prevention of non-communicable diseases, stress management courses, training managers and supervisors, employees, and also health workers in fulfilling their roles in the program. So these are components. And if workplaces are going to be including drug testing, it is also only as part of a comprehensive program. And lastly, I will talk about the community programs. And here, I think we have been doing fair enough, although we need to improve. Development of policies or enforcement of regulations. We are lucky in Kenya that we already have alcohol and tobacco policies. So enforcement is something that needs to be done. The mass media campaigns is also a community program. Community-wide awareness programs, the ones we do in barazas and other social events. So those are community awareness programs, but even then, you still need to ask yourself, who is my audience? Yeah, so that then your awareness is tailored towards the audience. Entertainment venues, the people in the region, you are familiar with this. We did this in the last 2 financial years, reaching out to entertainment venues, particularly with regard to underage drinking, training the people who are working there, and so on. So what is it that works? Prevention of sale of tobacco and alcohol to young people, enforcement and sensitization of retailers. That is what we were doing with the entertainment venues. You can ask yourself if you did it well, or you still need to pull up your socks. Support enforcement of tobacco and alcohol policies at the local level, and also a wide range of working in a wide range of settings. And we cannot overemphasize training and resources. I know our resources are low, but still training so that you're able to address the right content. Again, what works is targeting parents. It has been found that when you target parents, even children will listen. If you have a program that is targeting children, then they will resist. But if they hear it is for parents, they want to hear what parents are being told. So, in a subtle way, you reach them. So you should aim at programs, what works at cultural norms about substance use. Busa ni chakula, how do you address that? Because those are some of those cultural norms. How do you educate on the consequences of substance use? And then identifying precisely identify the target groups for media campaigns. And I can see media people are also here. How, how do we target, precisely target the given groups? And then also media campaigns still needs to be strongly connected to prevention programs on the ground, so that whether it is home, school, or community, there has to be a connection. And then adequate exposure of the target group over a long period of time. So it still shows that what doesn't work is a single event. The training of staff and management of those in entertainment venues, you need to have a strong communication component so that you can raise awareness and reinforce what is on the ground. Active participation of law enforcement, health, and social sectors, and also enforcing of existing laws and policies on substance use in entertainment venues and also in the community. So that is what works, and we are well represented here in regard to that. So finally, I talked about, so those are the programs that we have. You can see what we have on the ground and what we need to make better. At least we have somewhere we are starting. So we have areas that still require further research. Like we like sports activities, those leisure activities, the ones who want to do sports and say, oh, you know, sports, that helps to reduce drugs. It actually doesn't work. It actually doesn't work. But what is the research? So this could be one of the areas for further research. After school activities, I know it sells a great deal even in our own settings. But you should ask yourself, have you ever looked at whether that is working or not? In fact, in the school setting, the research actually showed that where drugs are used, when you have those events, yeah, when you have events in the schools, you have events in the schools. Those people who bring in ice cream and other foodstuffs, they bring a lot more than just the food. On the surface, this is what they have. Underneath, it becomes a good selling point for drugs. So monitoring and evaluation of prevention programs, we know that that is a gap on our end. So it's also an area that requires further research. Preventing non-use of prescription drugs, it has come out in our own researches. So we need more information on that. Policies that target children and youth, especially out of youth, school, and also children. I know we still have a gap even in terms of reaching out to those who are not in the school setting. So how do we address this? So it's an area of further research. And then interventions that are targeting families. Even our researchers, we have not been able to tweak out the component of families. So that may be another rich area. And then also the influence of media. Sometimes we want to use those who are in media because they have a big influence. What kind of influence do they have, positive or negative? So also that is an area of further research. So as I finish on this, we have booklets. Kindly get to the website. If you can't, as an Akada person, go to the website, other people will not go. You will also not remember that we have those booklets on our website. Have them. Maybe in future, when we have money we can produce. I know people demand more for hard copies so that they can keep, but because a lot of people also use WhatsApp and so on, they can be shared using those WhatsApp. So this is the question then that I'm asking you. Because we are in the process of change. Where are you in terms of this change? There are those who are innovators, yeah? Those who are driving the agenda. Yeah, like myself, I will call myself an innovator. Then there are those early adapters, those ones who see, okay, now I think this is the right direction to go. And so they will buy quickly into all these things that we have been doing with regard to prevention science. And I think we have many more people who are joining. So they are also early majority. Those ones who begin to see, yes, 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 I think I want to be on board. But we have late majority. Yeah, we have those ones who are joining now, which is good, because if you're joining now, and I would commend all of you who have even joined the workplace training, even though you are not directly involved in programming, it shows that you are also part of that change camp. You also want to be among the numbers and you want to make a change. Then we have the very late adopters. We have those ones who are waiting to see. Yeah, hii kitu ya Susan, wacha tuone itafika wapi. Yeah, so those are the very late adopters. So you ask yourself, where are you in terms of the change? Wherever you are, remember you can still make a difference. There are those of us who take long, there are those of us who jump on board very quickly. So thank you so much. And this is the point where if you have questions, you have comments, I hope the comments have been Wendy has been doing the chat. So if there are questions, you can raise your hand. Going one, no question. Two, none. Three, no question. Four, no comment. And five, thank you very much. So it doesn't mean that if you don't have a question, then you cannot ask later. You can still do email. You can have this discussion in your regional office, so that even as you think about the programs that you are implementing, or the ones what you'd otherwise call, or what we sometimes call the ad hoc. Even with ad hoc, you can still make a difference. Okay, so um, I want to commend our ICT department. Today, you're saying that was powerful presentation. The system has equally favored as well today. That is very true. So we commend them. So we'll be sharing this presentation with you because it is actually meant for you. Yeah, it is meant for you to disseminate, to use, and reach out to other stakeholders. All right, so we can take 5 minutes to just stretch as I change over to the next one.